Can everybody hear me? Yeah, okay, great. We're gonna go ahead and get started because I think we have to kind of hurry through everything, which is great.
Yeah, I think I have about 40 to 45 minutes today. I'm heading into a grand round presentation to support one of my colleagues here, so I just want to make sure that I have enough time to get to that meeting.
Yeah, so that's fine. We're gonna start with introductions real quick, and then we'll move right into the didactic, and then we'll take questions afterward. So let's see, Sam, do you want to start, Samantha?
Hello, this is Samantha Mann with Bluestone Health in Princeton.
Awesome, thank you. All right, and Kate?
Hi, I'm Dr. Kate Haswell. I'm one of the behavioral health providers at the Clendon Health Center.
Awesome, thank you so much. All right, the other person, it says Perez Weiss, is that right?
Nobody.
The Perez Weiss, can you hear us? You might not have a mic. Okay, if you can chat it to us so we can record you, that'd be great, but no worries. All right, and let's see, Heidi, can you introduce yourself?
I'm Heidi Bissell, one of the nurse practitioners at the Assistant Health Center. Sorry.
It's okay, thank you. Do you have anybody with you there today?
Kathy is going to be here, but she stepped out for just a second.
No worries, thank you so much. All right, and I know people will be coming and going. I see Chaba back there in the background. But so we're gonna go ahead. I'm Caitlin Eidinger, the West Virginia Project ECHO Coordinator.
And my name is Christine Pundick, and I'm going to be talking to you guys today about one of your requested topics, insomnia and psychiatric morbidity in primary care settings. And I'm going to share kind of a behavioral medicine perspective to treating insomnia today. So I can start by telling you a little bit about myself. I received my doctorate in clinical psychology in August, and I graduated from Adler University in Chicago, and I completed a predoctoral internship in primary care behavioral health at several federally qualified health centers in the Chicagoland area, primarily the south sides of Chicago. So primary care behavioral health integration is very important to me. And currently I am a health psychology fellow at WVU Medicine. I am doing 2 rotations, one in the pain center and one working with bariatric patients. And sleep concerns come up for both populations. So that's what kind of got me interested in, wanting to learn more about treating insomnia from a behavioral and cognitive perspective. So let's get started. I'll show you guys a brief overview here. Just trying to navigate this. Oh, there we go. So we'll review the DSM-5 criteria of insomnia. I know you guys are all familiar with insomnia, so we won't spend a whole lot of time on that. We'll talk about why we should address insomnia, why it's important. I found a really interesting study with a veteran population and common experiences of primary care providers in treating insomnia with that population. And then I'll kind of ask you guys, why this topic was requested, what your experiences are like in your current primary care setting. And then we're going to do a brief review for assessment of insomnia in primary care settings. I don't want to spend a whole lot of time on that just because there's other stuff that I think I want to spend more time on today, specifically the psychiatric disorders piece. We're going to talk about cognitive behavioral therapy for treatment of insomnia and the core components. We're going to review common psychiatric disorders like anxiety, depression, PTSD, and bipolar that co-occur with insomnia. And then we're going to talk about CBTI contraindications and other considerations moving forward. And then hopefully we'll have some time for questions and comments, but feel free to also let me know if you have any as we go through. So I'm just trying to change the slide here.
I think it should be able to click.
Oh, all right, there we go. So the criteria for insomnia disorder is the patient is reporting some type of dissatisfaction with their sleep quantity or quality, with complaints of difficulty initiating sleep, maintaining sleep, or early morning awakening with inability to return to sleep. So you might have a patient that comes in and says they feel like they haven't slept enough, they wake up several times throughout the night, they take a long time to fall asleep, they may report that they don't feel like themselves, their thinking has become cloudy, and everyday tasks have become challenging for them. In the 1970s, insomnia was considered a symptom and not a disorder, but insomnia is now considered a distinct diagnostic entity, even when it occurs simultaneously with medical or a psychiatric condition. So in order to be diagnosed with insomnia, you have to have these symptoms at least 3 nights per week for at least 3 months. Prevalence in primary care settings is part of 10 to 20% of complaints. It must result in clinically significant distress, so having an impact on areas in their life and they're distressed about it. So maybe impacting work or their relationships. And you can specify also mental comorbidity and with other medical comorbidity, like for example, chronic pain or other sleep disorder as well. So common experiences of providers and insomnia-related beliefs and practices. So there's just a statistic here that I think is helpful. 30% of the population experiences some insomnia complaint, and about 5 to 15% likely meet the criteria for an insomnia disorder. I found a very interesting study by Ulmer and others that looked at the veteran population, focusing on the perspectives regarding insomnia treatment among primary care providers working in the largest integrated healthcare system in the United States, which is the Veterans Affairs Healthcare System. The goal of their research was to examine common perceptions of the availability of insomnia treatments, to identify specific strategies offered by primary care providers, and to examine perceptions regarding the importance of insomnia and the role of comorbid conditions. And so there were several common themes that kind of came about in this research. And, I'm just curious, I kind of want to tie this into maybe what you guys are experiencing, because this was a requested topic. So as I go through these, I'm hoping that you guys can kind of think of what might resonate with you in your experiences of treating insomnia in a primary care setting. So the prevalence is often underestimated. Insomnia is infrequently asked about in routine visits. Insomnia is often not documented in the medical record. So insomnia is often viewed as still only a symptom of a disorder, and if it was treated, the insomnia would resolve. Other conditions are deemed as more important. Documenting a secondary condition may not be considered realistic with the constraints of a clinical setting. And when documented, it's not done correctly or to undermine its importance. And then fifthly, insomnia not usually treated following guidelines using empirically supported approaches. And one of the main reasons for that is due to lack of perceived CBTI as an option, either within their facility or a place where they think that they could refer patients to. So, I was just curious about, if any of these common themes have come up for you in your work in primary care, or if any of these ring true for you.
This is Samantha at Bluestone, and yeah, I have found the same thing here. Even if I address it, usually the primary care docs don't pick up on it unless I, point it out to them specifically.
And sorry, remind me of what your role is in the primary care setting. Are you a behavioral health?
I'm a counselor.
A counselor. Okay, so you bring it to their attention.
Yeah, I might bring it up, especially if an antidepressant is not also treating the insomnia. Mm-hmm. I might bring it up and say, you might want to address this separately.
Mm-hmm. Mm-hmm. And how do they typically respond to that?
Yeah, they respond really well. There's a few here that tend to pick up on it a lot, without me having to bring it to their attention.
That's great. That's very positive.
I think there's a lot that think that if they address the depression or whatever else is going on, that it should clear up the insomnia as well.
Mm-hmm.
Sometimes it does, but a lot of times it doesn't.
Yeah, it can definitely be variable. Because insomnia, as I'm understanding, can be a distinct disorder that deserves its treatment on its own as well.
Right.
Anyone else want to chime in about your experiences? No? Okay, so just for the sake of time, I guess we'll move on. Another interesting finding is that from this study, 43% of primary care providers were unaware of behavioral therapy for insomnia that was actually available in their facility. So it sounds like a lack of perceived treatment options may play a role in treating insomnia. But, insomnia is important to discuss because it plays a role into depression and other medical conditions such as hypertension, diabetes, and cardiovascular disease. So now I kind of want to quickly go over assessment in primary care settings. There are some different, very brief indexes and scales that you can use in a primary care setting that I think complement time-limited visits. So one of the scales is the Insomnia Severity Index. And are you guys familiar with this as well? I'm guessing you are. Okay.
Oh, wait, hold on.
Somebody's chiming in. So this is, okay, I see a question there. Frequent complaint, very often the people smoke. Yes.
Thank you both for the comments. Yeah, absolutely.
Thank you. So I have a copy of this as well that I can give to Caitlin here if you guys are interested. But basically it looks at severity of insomnia problems, so difficulties falling asleep, staying asleep, waking up too early, and they have patients rate them none, moderate, severe, very severe. Then they ask them about, how satisfied or dissatisfied they are, how distressed they are about their sleep problem, and of course the impact insomnia is having on their life. So this is a very quick and brief assessment tool to use that might kind of help you guide next steps. The Epworth Sleepiness Scale is an 8-item scale of daytime sleepiness. The one criticism to this is it's not actually good at distinguishing those who do or do not meet the criteria for insomnia, but it is better at identifying other sleep disorders like sleep apnea and narcolepsy. And a functional assessment of the sleep problem is really important. So, the Insomnia Severity Index and the Epworth Sleepiness Scale don't really give you a whole lot of context. And it kind of just talks about, patients' current functioning. But, behavioral health wants to do particularly a really good job kind of getting context of the person's life. So they might ask about history. So, when did you first start noticing a difficulty with sleep? Did anything happen at the time when your sleep problem started? It's important to ask about pre-sleep behaviors. So do you use anything to fall asleep? Alcohol, sleeping meds, what time of day you exercise? You might want to ask them about in-bed behaviors. So what time do you go to bed and how long does it take to fall asleep? When are you awake in bed and what are you doing when you're in bed? Are you watching TV? Are you reading? Are you eating? All of those things can impact sleep. Consequences, so do you take a nap? How long are your naps? Do you feel tired throughout the day? So I'm just giving you some, obviously it's much more extensive than this, the functional assessment of sleep problems, but I'm just giving you kind of prompts and ideas and questions you might want to ask in each domain. And then exclusions are sleep apnea, restless leg syndrome. So, whoops. So this is what I want to spend most of the time, talking about today, and that's insomnia and psychiatric comorbidity. So I had a lot of questions related to this that Caitlin forwarded to me. And from what I'm understanding, insomnia is both a symptom and a disorder on its own, and it can be a risk factor and a consequence of psychiatric disorders. And additionally, and importantly as well, insomnia can also serve as a risk factor for other different types of health conditions. So some of the things we might want to consider are depression. So for example, insomnia can represent both a risk factor or prodrome as a consequence of depression. Comorbidity with insomnia and depression is the greatest, with 90% of individuals with major depressive disorder experience insomnia. Those with insomnia are twice as likely to develop depression in comparison to those without the disorder. I think it's also important if people are coming in with sleep-related issues, it might be helpful to also administer a PHQ-9. I know that's used very much in primary care settings. Suicide, so insomnia puts a person 3 times the risk of suicidal ideation, attempts, and death by suicide. So there's this idea, and the research says that suicides often occur at nighttime, so there may be a struggle or issues with nocturnal wakefulness. PTSD, so a core feature of insomnia is hyperarousal. So insomnia may serve to increase severity of symptoms for both mood and anxiety disorders, but also hyperarousal, as we know, is a very core symptom of PTSD. Insomnia also plays a role in emotional dysregulation and can also be a consequence of insomnia. So negative emotional experiences can be more common at nighttime. And like I said, insomnia can also serve as a risk factor for other health conditions. So sleep difficulties 3 nights per week is associated with 18% increased likelihood of obesity, 18% increased likelihood of diabetes, and 59% increased likelihood of coronary artery disease. So those are pretty alarming statistics, and demonstrating why we should talk about it more, why we should treat it. And so the American College of Physicians has 2 recommendations. And the first one is adults to receive cognitive behavioral therapy for insomnia as the first line of treatment for chronic insomnia. And the second recommendation is for providers to engage in shared decision-making when the approach CBTI alone is unsuccessful. So let's talk about the number 2 here, the more unsuccessful piece. So pharmacotherapy is only recommended in cases when it's short-term or in combination with behavioral therapy or discussion with patients regarding the limitations medications may have. So therefore kind of highlighting why it's important to kind of have integrated health, because we are treating somebody from, a biopsychosocial perspective, and we want to look at cognitions, behaviors, and medications. So this is really the important stuff. So I want to bring this to your guys' attention, cognitive behavioral therapy for insomnia. And we're going to talk about the 3 core components. I found an excellent article, and that I want to forward to Caitlin here. It was by Garland and others, and Treating Insomnia in Patients with Comorbid Psychiatric Disorders, a focus review in 2018. So it's very recent research, and I think if you want to know the efficaciousness of CBTI in specific psychiatric disorders, like how it's useful with depression, how useful it is with PTSD and things like that, I recommend reading this. I didn't go into specifics with efficacy. I more so wanted to talk about it's efficacious, but also let's kind of go into, how it might look in a presentation, how insomnia may look for somebody who's depressed or somebody with PTSD and things like that. So I wanted to spend more time on that. So I just wanted to give you guys this really good resource here. These are 3 components. Stimulus control, I'm sure you've heard a lot of these, but this is gonna kind of set the stage for how I'm gonna relate it to, the psychiatric disorder piece. So I think it's important for us to understand the core concepts first. So stimulus control is, stimuli is typically associated with sleep are simultaneous with eliciting a good response of sleep in good sleepers. In insomnia, these stimuli are often associated with activities other than sleep. So reading in bed, watching television, and doing homework in bed. So lying in bed, awake, further strengthens the association between bed and wakefulness. if you're falling asleep in places other than your bed, such as your couch, it also strengthens the association between sleep and non-sleeping environments. So reassociation of bed with sleep can, occur in a number of different ways. So telling patients only going to bed when sleepy, getting out of bed when unable to sleep within 15 minutes, and returning only when sleepy. Some patients might say to you, but, what should I do when I get out of bed? Well, what if I become more awake if I get out of bed? So this type of thinking kind of represents that all or nothing thinking. And the best approach is to kind of move forward with, I guess, more of like a radical acceptance approach of telling yourself you're not ready to go to bed, so you may as well kind of get up and do something else. Getting out of bed at a consistent time each morning, irrespective to how you slept. So some people might say to you, well, I decided to sleep in today because I didn't have a good sleep throughout the night, but encouraging people to still get up at the same time and kind of have that consistent structure is really important. Using the bedroom for two things, I call them the two S's, sleep and sex only. Refraining from daytime naps. So those would be some recommendations for patients to address the stimulus control. Sleep restriction is basically kind of what the term suggests. So restricting the time in bed to the amount of time you are currently asleep. So one of the most perpetuating factors in insomnia is sleep extension. Most people notice sleep improves within a few weeks if they restrict their sleep. Sleep restriction can help people fall asleep faster, stay awake longer, and improve their overall sleep quality. This is typically derived from sleep diaries, so you wouldn't have them just do this sleep restriction activity without doing sleep diaries, and I can also forward Caitlin some of those as well if you guys would find those helpful. And you would want them to track 1 or 2 weeks prior to any intervention. So let's talk about application of this. So how would this sleep restriction kind of play out in a clinical setting? So you may have a patient who says their usual bedtime is 10 p.m. and they get out of bed at 6 a.m., but it takes them 1 hour to fall asleep. They wake up 30 minutes total in the night, and takes them 30 minutes to get out of bed. So they actually spend 6 hours total sleeping rather than the 8 that they're actually in bed for. So sleep efficiency is only 75% in the bed. So sleep restriction would mean decreasing the time in bed, so reducing it from 8 hours to the estimated of actual time sleeping, so the 6 hours. So the patient can either go to bed at 12 and get up at 6, or they can go to bed at, let's say, 10 and get up at 4, which is obviously, I think that's less ideal, but that's another example. Cognitive restructuring. So as we know, it's not the events that are inherently bad, but our appraisal or how we perceive events. Some patients may have common fears about sleep. Sleep loss is dangerous. If I'm not in bed by this time, over time I'm going to lose my job. You might want them to do a thought record. So that's kind of consistent, with what we do in, just regular CBT. You might also, engage in some Socratic questioning. So you might orient the patient towards coping. So if they've been reporting to you, I'm just going to be so tired all week, you might say something like, it sounds like you anticipate being tired this week. What kinds of strategies and coping tools might you put in place? So that might be a little bit more of a behavioral experiment that you're actually getting them to engage in. So CBTI efficacy, for short term, you might use it in combination with medication. Long-term patients, though, who receive maintenance CBTI, so kind of like ongoing as needed, typically discontinue off medications. So long-term, research shows that skills learned in CBTI are thought to kind of empower the individual, allow for self-implementation of skills, and if sleep difficulties occur, as opposed to medication, which requires continued use for continued benefit. So let's kind of break this down with different psychiatric disorders that you may see in a primary care setting, or that are pretty frequent, I would say. So let's talk a little bit about depression and anxiety and how it might show up and look. So for someone with depression, they may have the unhelpful cognition of, I don't feel like getting up in the morning. I really cannot get out of bed at 7 a.m. So they continue to either sleep more, which impacts their sleep later, or they spend a lot of time in bed doing activities maybe they shouldn't be doing, like eating or video gaming or whatever. So basically what's happened over time is that sleep in bed has served as an escape for their depressions, more of like an avoidance, which actually serves to maintain their low mood. But it's at first reinforced because, you know, they might be using avoidance to say, hey, I don't want to engage with people. I have low mood, so I'm going to retreat. I get relief, but then it kind of causes this negative cycle. So one helpful thing that you can talk to patients about is say, you know, you have to try to explain to them that they can't wait for the motivation and the feeling to arise, because that's going to make them less likely to get out of bed. They have to kind of learn the concept of acting first and feeling later. So having them think about doing things in the morning that you think might be helpful. So you may want to explore with the patient to identify some actions they might do in the morning. So maybe they can identify, okay, so I'm going to meet my friend for coffee at 8 a.m. I'm going to meet my friend for the gym, or I'm going to get up and I'm going to go for a walk. Like scheduling a pleasurable activity or something that's going to kind of get them up and their energy going. So you can provide some psychoeducation as well. You can say how more time in bed actually puts them at risk for poor sleep later, and how avoidance actually plays a role in maintaining their low mood. So let's go on to anxiety here. It's often a bidirectional relationship. Sometimes stimulus control instructions are not really all that tolerated. Sometimes they fear, the bed becomes kind of a place of fear. Sometimes anxious folks are more preoccupied with kind of getting these techniques right, getting these techniques perfect, which only actually serves to increase their anxiety at nighttime, which is not helpful. They may also be overzealous about getting out of bed in the middle of the night, that it does not allow them to fall back asleep. So application of this, so knowing what we know about anxiety and insomnia, what might be a helpful intervention. Some of the research shows you can try a paradoxical intention, which is saying, let's try to remain in bed as long as possible tonight and see what happens. And what this intervention does is anxiety and sleep effort is reduced kind of through this paradox and through this intervention. And it's most helpful for those with sleep onset difficulties. So PTSD is another common presentation that comes up in primary care settings. Most of the research for CBTI I noticed was very much talked about with anxiety and depression. It's less developed in comparison with for PTSD, application of CBTI and PTSD than other disorders, but it's still worth talking about because it's still in the literature. Sleep disturbance is a very common symptom of individuals with PTSD. And I want to go through, you know, talking about some common experience of those who have PTSD and some of their thought processes so that you can kind of better understand how insomnia may show up in this type of disorder. So patients with PTSD might have a fear of silence. So maybe they have a really hard time sleeping with no distractions. Maybe they need to have music on. Maybe they need to have the TV on. Something there that's kind of helping them. They might have the cognition that silence is, they might associate kind of silence with fear. So you might recommend stopping the TV and replace it with more of a white noise, which is still something that's happening in their environment, but it's a better alternative than a TV going. They may fear a loss of vigilance. So they may say to you, well, I may not be able to react or defend myself if bad things happen when I'm asleep. So that's why they might have difficulty falling asleep, because they think something bad is going to happen once they do sleep. So you may want to discuss with them perceived threats and the likelihood of counter evidence. So help them turn trust in their ability to, you know, react to a threat when it does come up. You may also talk about how a fear of vigilance may actually result in more deprivation. And what does more deprivation do? More deprivation will make them more vulnerable to, you know, nightmares and things that they don't want. So you might want to talk to them about that as well. Delayed bedtime. So I am not tired at night. You might want to have them use self-monitoring to increase their awareness. You might want to have them do in-bed stimulus control. So have them set a timer for 20 minutes rather than waiting for sleepiness. Sleep avoidance. So you may hear them say things like, I just really dread going to bed. I don't want to go to bed. This is where you have to kind of ask more. So, saying what you really want to know is, what are they avoiding? So what is it about bed that they're avoiding? And explain that deprivation and fatigue actually reduce their coping and makes their symptoms worse. And then prolonged nightmare awakenings. Some patients might get up in the middle of the night and try to figure out the meaning of their nightmares. So bipolar disorder and CBTI. So 70% of bipolar disorder patients report a clinically significant sleep disturbance. That's a pretty high number. And sleep disturbance is a core feature of bipolar disorder and the most common prodromal symptom. So what I have found in the literature is that bipolar patients who tend to have shorter sleep tend to exhibit several different symptoms. So more symptoms of mania, depression, anxiety, irritability. Shorter sleep time is associated with mania and depressive severity over 12 months. And total wake time in the morning was associated with next morning negative mood, and evening mood associated with longer wake time following the night. So in the literature, it says CBTI is not particularly recommended, but there are kind of adaptations or modifications of CBTI that can be useful for bipolar disorder, and I can give an example. But let's just go through some of the recommendations as to maybe why it's not helpful. So just kind of thinking of the symptomatology of bipolar disorder. So they may not sufficiently reduce goal-oriented behavior before bed. So it might be hard for them to adhere to the whole wait to get sleepy before bed. Getting out of bed in the middle of the night may actually increase rewarding, arousing, and productive activities. And short-term sleep deprivation is associated with sleep restriction, might trigger a hypomanic or manic episode. So all things we don't really want. So there are some adaptations. I didn't really go into this a whole lot just for the sake of time, but an example of how you might adapt the CBTI to those who are diagnosed with bipolar disorder is stimulus control recommendations may need to be adjusted. So you may recommend activities that allow for more relaxation in bed rather than getting out of bed and doing something. So let's talk about CBTI and contraindications and other considerations. So there are some populations and some presentations that CBTI is not all that great for if there are other concerning things going on. So somebody with a current substance use disorder, at least working with the pain population, I often hear, marijuana helps with my anxiety, marijuana helps with my sleep. It helps with sleep initiation, but not really the quality of their sleep and feeling rested. Psychological instability. So if they're undergoing a crisis, CBTI would not be the first line of treatment. If they are medically unstable, so if they have epilepsy, bipolar illness, as we talked about, and if they have untreated or poorly treated sleep apnea, because there might be some other different types of medical interventions that might be more useful before implementing kind of the aspects of CBTI. So also what I found in the research, there was a common theme, is that CBTI is very underutilized as a treatment, despite its efficaciousness. So, I'm curious with you guys, how much do you guys know about, CBTI? Do you guys practice this in your facilities? I don't know a whole lot about what your facilities look like, but do you guys refer out to providers who specialize in this, or what does that look like for you guys?
And everybody is muted, so make sure you unmute yourself if you want to go out. Thank you, Vanessa. So Vanessa's a nurse practitioner. She refers out, but she can also provide suggestions for it.
So you know of specific places that you can refer to and you feel comfortable doing that. I'm just curious, what kinds of suggestions do you provide? I mean, I'm sure it's obviously dependent on the patient's presentation, but do you have like a specific go-to for suggestions?
So one sleep specialist that I listened to made a comparison of falling asleep to landing a jet engine rather than a light switch. Yeah, absolutely.
I like that. Sorry guys, I'm having a hard time seeing here.
It's okay. It's pretty far from us, but
we deal with it in therapy and provide handouts to patients. Cool. Is there a specific site that you guys are getting your handouts from that you find particularly useful?
Samantha, I have an integrated care book that I cannot remember the name of right now.
So
it has lots of handouts.
Is it called the Integrated Behavioral Health and Primary Care Step-by-Step Guide?
Yes.
Have it right here. It was awesome too.
Yes, I loved it.
It's really great. Honestly, I think, you know, it's great for clinicians, but also any type of provider in a primary care facility, I think, could benefit from this knowledge because I think it's written in a very simple, very straightforward way, very applicable.
awesome. Vanessa had another comment, said that another suggestion that I suggest is another sleep specialist suggested to you is thinking of random things in the mind's eye until you fall asleep, like a cup, a tree, a dog, however that may be.
Okay, I could see that working for sure. I've read several books
Sleep
about
your way
sleep.
to the top. I love it.
So it sounds like, you know, you guys are really doing a good job in supporting your patients work through sleep complaints and insomnia. And it sounds like you guys have some really good resources that you're giving to patients and that you're also kind of doing on your own as well.
Oh, Emily, are you guys trying to talk? No? Yes. You can't.
There you go. She was just looking at the screen.
Sorry, I
Sorry.
was just trying to catch up since walked in. My bad.
No, I just wanted to make sure that we weren't ignoring you.
No, I just leaned in to try to read. My eyes aren't the best.
So is that it?
Yeah, so that's all I have for today, guys. I thought I was going to take the full 45 minutes, but I must have just talked really fast, so I apologize about that.
I'll send that out to everybody, of course, but what kind of questions do you guys have?
Oh, this is Samantha again. I've been looking for some suggestions to help people who tend to sleep during the day. I find that they're real resistant to changing that pattern.
Do you mean like, so I'm going to need a little bit more context. Are they sleeping during the day, like their full, like that's like their bedtime, they're sleeping during the day, or they're napping?
They're sleeping during the day and getting their usual and I guess the 6 or more hours of sleep during the day and staying up all night.
So are they doing that because they're working nighttime work, like night shift?
No, most of the patients I have doing that are dealing with anxiety and just stay aroused all night and then go to sleep during the day.
Okay. Have you tried any of those CBTI core components? I mean, to help them get a more restful sleep at a more reasonable hour in the nighttime?
Yeah. And I've tried walking them back bit by bit, like having them wake up earlier and earlier so that we could try to walk it backwards.
Like by increments?
Yeah.
What do you typically suggest for that? Like 15, 20-minute increments per night, or like what is it typically for you? Do you suggest?
I've been suggesting like an hour at a time.
Okay.
Try to wake up an hour earlier and go to bed an hour earlier.
They notice
They're real resistant.
You know, I mean, when I think of anxiety at night like that and like more of that hyper arousal, I guess, I think of like relaxation strategies that come to mind, like mindfulness, progressive muscle relaxation. Those are very skills-based exercises. So, you know, they're things that they can learn over time, and you can do it with them in session and practice the skill with them.
Okay.
Have you tried any of those things?
Yeah. I don't know that I really push to do those things with the scale back their sleep.
Mm-hmm. Mm-hmm.
Maybe I could just push that a little bit more and see if I can pair them up together.
Mm-hmm. Yeah, I mean, I'm curious about, you know, are they feeling anxiety in their body at all? Like it may not just be a cognitive thing for them as well. It might be like increased heart rate, you know, there could be other physical symptoms that might get in the way of that restful sleep as well. So maybe just kind of helping them connect some of their symptoms to their body as well might be kind of helpful, and just helping them be more aware of that. And that's where progressive muscle relaxation would really come in handy.
Yeah. I think maybe part of the problem is they just have paired nighttime with worry time.
Mm-hmm.
Something about the dark that's more easy for them to do that.
Yes. I know there's like this like worry later technique that I sometimes try to use with patients, like giving them a specific time limited where they can just worry, like 5 minutes, 10 minutes, where they like have a designated time. And sometimes that can be helpful. Obviously, you would not suggest that before bed, but it helps their mind kind of, if they know, they can just compartmentalize it, kind of thing.
Heidi or Alexandrina, do you guys do anything like that for people who have that reverse sleep schedule type thing going on?
That is not something that I've tried, but that sounds interesting. Definitely. As far as having them scale back the amount of time that they're in the bed, and, you know, keep a journal for how long that they're actually sleeping, and then, you know, target spending that amount of time in bed. That's definitely something I'll start trying.
All right, so it's time to run to ground rounds for them. Thank you so much, Heidi. I didn't mean to interrupt you. I did see where Vanessa, you're fine.
Oh, I'm good?
Yep, you're good.
Okay.
And then we'll follow up. Any questions or something, we'll make sure you guys get answered and stuff, but we'll keep going here for a second. I just see where Vanessa said that the book she referenced earlier, Sleep Your Way to the Top, says that there are people that are naturally night owls or larks. And so see if they are oriented to one way or the other, that they won't change. It just goes beyond a personal choice and something that's more inherent in people. And it kind of takes further exploration to see if that is something that needs to change or not. So maybe, I mean, and I'm just thinking, but maybe orienting them to like a nighttime work position isn't the worst thing for people who naturally like to be awake at night. But definitely. Were there any other questions you guys wanted to hear about? Dr. Goodykins wanted to be here today, so she's going to follow up with some of the medication questions if there were any. Nope. Okay. Well, wonderful. It was a great session. Thank you, Christine, for doing that.
Thanks for joining me, guys.
Yeah.
Take care.
And everybody, if you guys have other questions, just forward them to me. We'll get them answered for sure. And thank you guys all for the comments in the chat. I really liked that kept going through the whole thing. So our next session is the 19th. I will let you know. We do have somebody scheduled, but I want to confirm with them before they do or do not show up. And I will, of course, remind you about that stuff. But thank you all.
Thank you.
Thank you.
Thank you.
Thanks.